my slide on your screen?
Yes.
Yes. Okay.
Yes,
So
sir.
thank you very much. So we start now. You remember we are completed already with the main part of gastrointestinal tracts. From oral cavities, we move to esophagus. Then we have stomachs and intestine. Yeah? So the lecture 7 cover more on the actually lesion associated with GIT, and one of the most important part is the peritoneal cavity. But please do remember also that apart from the abdominal cavity, diseases of GIT also might interfere in the thoracic cavity, because when there's some disturbances or abnormalities of the esophagus, there's tendency also, particularly when there's a perforation of the esophagus, might be some leakage of the esophageal content with my move into the thoracic cavity, then also might lead to lesion observed in the thoracic cavity. And the most common one, of course, is what we call it, abscesses may be present in thoracic cavity. And not, when they move further down, of course, most of the organ of a GIT are present in the abdominal cavity. We have their stomachs, also the intestine, small and light intestine, and partly also liver also is part of the GIT, partly because liver has direct communication from the GIT through the bile ducts. So more organ actually present in the abdominal cavity, and complication may occur whether it is a result of a perforation or it is a result of any changes of the GIT cell. And similarly also, if there are changes in the abdominal cavity, they will lead to disturbances of the GIT. So that's why abdominal cavity, or sometimes we call it, in this case, we call it as a peritoneal cavity, are important with regard of GIT diseases. And another important part, I think in any other part of the organ also, one we call it a tumor, is neoplasia. Neoplasia is something that is very important, but yet I think in this case we touch very briefly, although it is a very important diseases or condition, which currently people have a very great challenge with regard of therapy of a cancer. Cancer or neoplasia is something very challenging. There are a lot of medicine developed, medication for therapy, but yet the effectiveness to cure cancer is still, not to say questionable, but still a big challenge, depending also on the degree, severity of the neoplasia at the beginning of the treatment. So we're going to cover today on the peritoneal cavity and the neoplasia part of it, and then we'll move second on this on the next lecture, which is our lecture 8. We're going to go into the liver. So we have 2 lectures on liver. So today is we have 1 lecture, another one, the last lectures that we're going to have will be on Wednesday to cover up on the liver. So peritoneal cavities, what most important is that what is the content of the peritoneal cavity. As I'm telling you, sometimes we call it peritoneal cavity, but actually if in general term, we might call it as abdominal cavities, because the peritoneum is very thin membranes, just like a balloon, that really give a very good cushion or buffer of the visceral organ present in the abdominal cavity. So one abnormalities, the common one, of course, is the abnormal content. Abnormal contents, whether it is abnormal content as a result of perforation of the GIT or as a result of anomalies of the GIT, but it can be also external content resulting for other factors as well as other external factors. For example, if animal have infection direct to the abdominal cavity, there will be lesion in the abdominal cavity, and that lead to what you call it disturbances of the GIT organ. And one of the most important, like other organ, you remember the intestine, we have enteritis, oral cavity, we have stomatitis, and when you go to the stomach, we got gastritis. So inflammation also still play a very important role in the abdominal or peritoneal cavity. And the inflammation of the abdominal or peritoneal cavity, we call it as a peritonitis. Yeah? So that peritonitis, we discussed earlier also when we talk about perforation of the GIT. Then the second part, we try to look more on the neoplasia of GIT. Normally in GIT, we try to look more on the neoplasia and sometimes neoplasia-like lesion. What I mean by neoplasia-like lesion is that the lesion sometimes look like neoplasia, but actually they are not neoplasia. And this is something that very common even in cases of active granuloma, for example. Sometimes it look like a neoplasia, but actually they are not neoplasia. So that's why diagnosis of neoplasia is so important, partly because accurate diagnosis is important, because if we make a wrong diagnosis, we thought it's neoplasia like lesion, but actually they are neoplasia. Of course, they can cause a very bad feedback to the patient. Similarly, also when you talk is actually they are neoplasia like lesion, but diagnosed as neoplasia, they also give a very what you call it negative impacts regard of treatment and many other things. So it's very important for us to understand about this. But the basic thing is that we might not go in details. We like to also review on type of neoplasia, and then how we're going to differentiate between different type of neoplasia based on histological features and nomenclature of both the epithelium and connective tissue neoplasm. So we're going to touch briefly in this lecture. So when you look at this peritoneal cavity, and when you want to conduct necropsy, when you want to open the abdominal cavity, after cutting the skin, then you will cut the muscle. Then before, just immediately after you cut the muscle, with very careful, you later on you expect to see a very thin membrane, a very thin membrane. It is actually a very thin membrane where actually in normal one, they are more clear we compare with cloudiness when there is peritonitis. So sometimes we might miss those of these, what I call it, the peritoneal membranes, because it's just a single unit, incompletely divided into compartment by mesentery, omentum, ligament, or double peritoneal membrane. So just with a very care approach on exposure of the abdominal cavity during necropsy, you might appreciate to see of these double peritoneal membranes. Sorry? Can you hear me? Hello?
Yes, Prof.
There's some disturbance or anything? Sorry. I thought a question, not a question, yeah? Okay, so when you want to appreciate this peritoneal membrane, you really need to do a very careful when you open the abdominal cavity of the animals. Yeah? Particularly maybe in ruminants, it's much more easier. You open very carefully. Then when you open, just see very thin. I could say like maybe like a balloon. Just like a balloon actually, very thin. And if you don't do properly, when you're cutting step by step, you cut the skin, then after that you cut the muscle. Before enter the abdominal cavity, then they will see very thin membrane, which is actually the peritoneal membrane. In normal condition, this peritoneal membrane is almost like colorless, yeah, like transparent. But in instance of infection, of course, they are become cloudy, and occasionally they also become thickened. Yeah? So this is a peritoneal membrane. But the important thing is that they are more putting as a buffer to make sure that organ in the abdominal cavities are in place, particularly during a normal condition. So what you expect to see in this peritoneal cavity? I mentioned earlier, we always talk about peritoneal cavity, but in the same time also, probably we can consider this as an abdominal cavity. Yeah? So the content probably can be a foreign body. I mentioned earlier ingesta, and this ingesta commonly is from the GIT, isn't it? When there is a perforation, for example, there's fungal infection in the rumen, then in chronic condition, those rumen get perforated, then that might lead to exposure all the ingesta present in the rumen into the abdominal cavity. So you can expect to see the ingesta. But the challenges is that, as I mentioned earlier, like in cases when you conduct necropsy, particularly in rabbits, when you open, many times you see that the stomachs actually it has been ruptured, and then you can see those stomach content exposed from the stomach itself. So it might be present in ingesta in the abdominal cavity, but this changes actually is more of a postmortem change, not a lesion. So how are you going to differentiate that? As mentioned many times, when it is postmortem change, you don't expect this to respond to injury. This meaning that if there is stomach ruptured, of course there will be hemorrhage. It might be hematoma there. And in long run, if stomach ruptured, you expect will be a peritonitis. So it's very important to differentiate between postmortem change, or in this case, normally is agonal change actually, postmortem change during handling of the dead carcass, leading to rupture of the stomachs. They must be what you call looking for tissue response to injury. Another possible, what I call it, abnormal content is hemoperitoneum, meaning that presence of blood in the peritoneal cavity. So this something also is very important for you able to differentiate, because occasionally when we conduct necropsy, there's tendency also for us accidentally hit the blood vessel. When they hit the blood vessel, there's a tendency that of those blood might ooze out, or maybe those clotted blood might ooze out into the peritoneal cavity or the abdominal cavity, and it looked like a hemoperitoneum condition where if animal have ascites, for example. So you can see, like hemoperitoneum, present blood in the peritoneal cavity. Again, it's very important for us to differentiate between hemoperitoneum, which is a lesion, or it is just a postmortem change where there is presence of blood in the peritoneal cavity. The key point again is to see response to injury. So in many instances, this hemoperitoneum might occur as a result of a liver, spleen, or even kidney injury. Yeah, of course, in our case, quite common, maybe GIT referred to liver injury. Sometimes the animal might have hurt, traumatic injury, impact of very strong force in the animal cavity might lead to rupture or damage of the liver, and animal might have hemoperitoneum. Of course, in that condition, we'll expect to see also traumatic injury in the liver. But many instances also, they can be as a result of viral infection. For example, in cases of infectious canine hepatitis, ICH, they might have also this blood in the abdominal cavity. Neoplasia, the neoplasia, they involve quite common when they have what you call it splenic hemangiomas. This is quite common in equine, particularly those equine with white or gray feathers, or gray skin. So you expect to see this, what you call it, they have neoplasia with regard of splenic hemangiomas. We have seen a case for that actually. Yeah, I mean that there is a neoplasia in the skin. And not forgetting like warfarin poisoning. Warfarin have been used as a poisoning agents, and in that case, particularly in rats, you might expect to see those, of course, what you call it, hemorrhage or blood in the peritoneal cavity. So hemorrhagic is very important. Presence of hematoperitoneum suggests also some diagnosis or the agent that can cause that. But the care that we should have is that make sure you are able to differentiate between hematoperitoneum with then what you call it post-mortem change. So that is important to differentiate because the presence of hematoperitoneum is very significant and they are caused by certain agents. Another very common is hydroperitoneum. I think this hydroperitoneum is quite common, particularly what you call it, when animals have hypo low of protein in the bloods. Yeah? So hypoproteinemia, the accumulation of non-inflammatory isolate in the peritoneal cavity due to dismissed removal or overproduction of fluid. So ascites or hydroperitoneum is one of the differential diagnosis for overdetention of abdomen. So remember that another differential diagnosis for overdetention of abdomen is tympany or bloat. Yeah? So the cause of hydroperitoneum can be as a result of diaphragmatic lymphatic obstruction, can be also as a result of right-sided congestive heart failure, or occasionally due to chronic fasciolosis. This partly because disturbances in mesenteric and hepatic circulation. I think in cases of right-sided congestive heart failure, this occurs partly because there are increase of blood pressure. Please remember when we talk about edema, edema is a balance between the blood pressure, blood osmotic pressure, tissue pressure, and tissue osmotic pressure. So in cases of right-sided congestive heart failure, there will be backflow of blood circulation from the liver into the right side of the heart or right side of the heart, and as a result of that, there will increase in blood pressure. When increase in blood pressure, there will be poor fluid to return back into the circulation, and they will accumulate and lead to condition called as ascites or hydroperitoneum. Cases of intoxication, I think the same also, but intoxication, this partly because of dilatation of blood vessel that lead to accumulation of fluid as well. And cases of acute uremic syndrome, and or I mentioned earlier in cases of hypoproteinemia, reduction of albumin, particularly in the blood vessel. So against the balance between blood pressure, blood osmotic pressure, tissue pressure, and tissue osmotic pressure is disturbed. So reduction in protein leading to reduction in blood osmotic pressure. That's why the fluid will accumulate, in this case in abdominal cavity, but in cases of hyperproteinemia, I think another common site actually is the lung. Yeah, the lung is most common site because of the sponges nature of the organ. They are more spongy. Any questions so far? Class, any question? No? No, thank you. I proceed. Yeah, this is one of the most common in all organs, but now, of course, more common in the abdominal cavity. Inflammation of the peritoneum, we call it as a peritonitis. As mentioned earlier, normal peritoneum, they are smooth, a shiny membrane, very clear. But it got infected, of course, they become thickened and cloudy. So peritonitis is more common in large ruminant or large animal rather than in dogs and cats. Dog and cat, they are less common actually. But in large animal, they are more common. And depending on the type of changes that occur, but probably they can be classified as serofibrinous, where you can see the fibrin, and then fibrinopleuron when there's an infection, or sometimes they got also hemorrhagic peritonitis. And the distribution of lesion, I think, can be localized or generalized depending on the type of agent that lead to those of the changes. And as usual, this peritonitis can be acute, subacute, or chronic. So this liver of cattle, you can see that the hepatic parenchyma is darkened, it's very darkened. And those you can see about whitish material in this case, covering the capsular surface of the liver. And this is actually fibrin, yeah? But of course more advanced. If it is acute stage, we expect this fibrin, the color is more gelatinous, big yellowish, yeah? Mild yellow gelatinous material. But in this case, you can see they are more cloudy, yeah, more cloudy, which is showing that they are more in advanced stage, maybe subacute lesion. So how this fibrin actually present here, they are same mechanism of fibrinous enteritis, you remember, where there's very severe inflammation of intestine at a stage where the fibrin from the blood vessel escape, and that lead to what we call it fibrinous enteritis. But in very severe form, they might also rupture a blood vessel, then they might cause also fibrin and hemorrhages. But in this case, again, there is severe inflammation of the liver, and as a result of that, the blood vessel of the liver partly is become dilated, and those fibrin will escape and covering the surface of the liver. So this is a condition called fibrinous hepatitis, but in this case, this condition is much more of subacute rather than the acute, because in acute form, you expect to see clear exudate where the presence of gelatinous materials. I think it's very common also in chicken when they have chronic respiratory disease complex. And peritonitis, like others, they might be primary or secondary. As mentioned earlier, the classification of primary and secondary is matter of approach in the treatment, which is very important. Yeah, because it is primary, they actually directly, the agency direct into the abdominal cavity. For example, then, if animal have a perforation of GIT, so very direct, the perforation of GIT leading to peritonitis, perforation of reproductive tracts leading to peritonitis, maybe rupture of the urinary bladder leading to peritonitis. So this is more direct one. Which is actually in terms of treatment is much easier because you can avoid those incident or occurrence of this perforation or rupture, either GIT, the reproductive tract, or even the urinary system. But the secondary is always as a systemic condition. And usually in this systemic condition, animal have septicemia, yeah, mean that the agent present in the blood vessel, and that lead to disturbances or infection that occur in the abdominal cavity or in the peritoneal cavity. Example there, tuberculosis, of course, feline infectious peritonitis due to coronavirus, strangles, and Glasser diseases in pigs. So this is a secondary. When you see peritonitis, against animal actually have a systemic infection. And it can be acute, can be diffuse peritonitis or localized peritonitis. And when they diffuse, it can be acute or chronic. So in cases of acute diffuse peritonitis, usually could be as a result of rupture or perforation of GIT, or maybe infectious canine hepatitis, viral infection. Sometimes, like in cases of infectious feline peritonitis, and in cases of septicemic pustulosis, you might expect to see this acute diffuse peritonitis. One more important is that when you open the carcass, then you see there is acute diffuse peritonitis. Again, what you should consider in your mind is what is the differential diagnosis of this acute diffuse peritonitis. But of course, before you're able to put those differential diagnoses, more importantly is that you must able to recognize how this peritonitis look like. That's the first step that you're going to able to recognize. It is a lesion, it is peritonitis, then only you are able to think about the differential diagnosis. That's why description of lesion is so important. Recognition of lesion is so important. So usually in cases of acute diffuse peritonitis, you expect to see these hemorrhages in submucosa, maybe some exudation and fibrin deposit, and maybe also fresh adhesion and pleuron. So of course, in this case, very simple because the hemorrhage there, you got fibrin there. Sometimes you might see also pleuron mean abscesses, yeah, or suppurative material. So quite straightforward, isn't it? Because the lesion is there. Of course, when you do histology, that's not less important. Leukopenia, neutropenia, marked increase in immature neutrophils. So you are able to differentiate because the lesion is quite clear. Got hemorrhage, got fibrin, as well as you have see also those of suppurative material. In chronic is more the advancement of the acute, yeah, and we may see a less fluid and often forming a thick tissue covering over most of the viscera. A chronic form usually to the bacterial infection, like Fusobacterium necrophorum or Echinnomyces. So this is more of a chronic diffuse peritonitis. But others also, they might have also what I call localized peritonitis. And of course, this localized depending on the development of lesion. For example, traumatic reticular peritonitis, where you can see there's a common one is foreign object that poke the reticulum and then formation of what I call it tissue response around the area. So traumatic reticular peritonitis also in advanced stages could lead to damages of diaphragm as well as cause damages of the heart as well. So due to the foreign materials, I think we have discussed that also. And sometimes in cases of Strongylosis, they are more on the chronic localized peritonitis. So why is so important like this peritonitis? Okay, of course, peritonitis, if not been intervened in terms of a treatment, can lead to death of the animal, isn't it? One potential of death is a toxemia or septicemia. You always understand when it's toxemia or septicemia, there will be a dilatation of blood vessel, accumulation of blood in the peripheral blood vessel that lead to poor venous return, leading to low cardiac output of oxygen and nutrient, and ischemic necrosis of vital organ, particularly the central nervous system. And that failure of vital organ leading to ischemic necrosis of the vital organs that lead to failure of the brain or central nervous system, the brain, the respiratory center, and probably also the cardiovascular center, leading to death to the patient. In cases of peritonitis also, they might lead to shock. Shock partly because as a result maybe as hemorrhage, or partly also as a result of a lot of fluid loss will lead to ascites. So because what happens when there's ascites or even hemorrhage, accumulation a lot of fluid in the abdominal cavity or in the peritoneal cavity, that will lead to a gain of a poor venous return. And then the mechanism is the same. Then it can lead also complication of adhesion, meaning that when chronic peritonitis, there is a tendency that the serosal surface of the organ might adhere to each other. Yeah, then might lead to torsion, might lead to abnormal mortality of the GIT, and they might lead also complication depending on what type of this, for example, obstruction or maybe torsion, and that might lead also to death to the animal. As I mentioned earlier, peritonitis also could lead to abdominal distension, and cases of abdominal distension, when you refer to cause of death, they are same mechanism, almost same mechanism, what we see in cases of tympani or in cases of blood. So this is how peritonitis is so important, because when they say peritonitis caused by various agents, at the end of the day, it can lead to toxemia, septicemia, shock, hemorrhage, adhesion, abdominal distension, and all this could lead to death to the animal. The mechanism of death I mentioned to you earlier. Let me move to the second. Any question for the peritonitis? Very straightforward, eh? Okay. So let me move to the second one, more on the neoplasia. So this more on the review. I think just very brief visit on the neoplasia, particularly on histological feature of neoplasia. We have benign or malignant, and normally benign, they are only locally growth. Eh? While malignant, they can cause metastasis, metastatic, so that is very important. Particularly benign is less risk we compare the malignant, because they are only a pensile grow only, while in the malignant, they are more invasive. So meaning that this can be differentiated in terms of diagnosis. You look at a grossly, probably, benign, you might see only one place. But when you got malignant, when you open the carcass, there's a tendency that neoplastic tissue in the main organs, but also maybe find on the other organ. So that's a grossly. But histologically, of course, malignant, benign, they are only localized, but in the malignant, the cell is more aggressive and they look more invasive of the surrounding cell. Okay, so that can differentiate of these two. I mentioned earlier, in addition to that, when you do histology also in benign, the cells are well differentiated. You can see the cell resemble to each other or the cell in origin. Mitosis is less, and you see the ratio between nucleus or cytoplasm, they might be normal or slightly increased. I mentioned here the cell is resemble cell to each other, well differentiated, and the cell are uniform. But of course, in malignant, there's a lot of different type of cell, their sizes, appearance, yeah? Numbers of mitotic cell, as well as high nuclear to cytoplasmic ratio, shell varying in shape and size, we call it cellular polymorphism and nuclear polymorphism. This is just a basis of benign and malignant tumor. I mean, for you just to recall back what we have learned, but to me it's very important of the criteria for us to differentiate between what I call it benign and malignant. And in terms of the culture of the epithelial neoplasia, particularly like in the oral cavity, we have squamous, what I call it, we have squamous cell, stratified squamous cell. So surface epithelium, we call it papilloma, and malignant, we call it a carcinoma. Oral cavity is run by stratified squamous epithelium. Squamous epithelium, in malignant, we call supercell papilloma. And in malignant one, squamous cell carcinoma. I think it's quite common to see this squamous cell papilloma as well as squamous cell carcinoma. I think throughout your practice, even before you graduate, you expect to see, I think this type of lesion. And sometimes in cases of squamous cell papilloma, the treatment sometimes is mainly straightforward. You might damage some of the cell, then it might regress, particularly squamous cell papilloma in the oral cavity. I think I've seen a case of this. I'm handling a case of this squamous cell papilloma in the oral cavity. Of course, there's a number of cases of squamous cell carcinoma, particularly in the cat. So we have also glandular, where actually glandular like the stomach. So we have adenoma, but malignant we call it adenocarcinoma, isn't it? So this in relation to the gland, particularly the stomach. Transitional epithelium, this more in the urinary tracts. The urinary tract, particularly the bladder, they have transitional epithelium. Then you got transitional cell papilloma, enteral cell carcinoma, and in gland normally, I mentioned we call it adenoma and adenocarcinoma. Other than that, we might also on the fibrous tissue with fibroma and fibrosarcoma, smooth muscle, leiomyosarcoma, skeletal muscle, rhabdomyoma, rhabdosarcoma. This is quite less in GIT. Yeah? Adipose tissue also less, lymphoma, lymphocytoma. Of course, cartilage not involved in GIT, chondroma, chondrosarcoma, and the bone osteoma, osteosarcoma. So in the oral cavity, I mentioned to you earlier, squamous cell carcinoma and papilloma is quite common. They might say Z. Occasionally also you might see this malignant melanoma, particularly in dogs. You can see that there is a pigment which is actually black in color that present in the oral cavity. That's malignant melanoma. And there's also fibrosarcoma. And this all is very common in the oral cavity. But sometimes also, particularly in cases of pyogenic granuloma, they sometimes might look like fibrosarcoma. Actually, they are granuloma. Granuloma is a result of chronic inflammatory reaction, usually due to the, what we call it, a bacterial infection. Gingival hypertrophy sometimes look also like a, what we call it, maybe papilloma, but they actually hypertrophy. And upper also occasionally look like neoplasia. So again, these are challenges between neoplasia and neoplastic like lesion. But of course, it's very straightforward for us to identify squamous cell carcinoma, malignant melanoma, and papilloma. Maybe fibrosarcoma is a bit challenging, particularly you have case of chronic pyogenic granuloma. There's more challenges. Then you go to the gastric neoplasia. Of course, adenocarcinoma. This adenocarcinoma is something that is, I could say, straightforward and easy to diagnose. But sometimes they have also benign changes, where we call it as adenoma, which is benign polyps, which is unclear. And animal with these benign polyps, usually they might occasionally show vomiting of blood. Blood. When they vomit, they find the blood inside in the frank blood in the vomiters. So of course, this will worry of the clients in it because they don't have vomited blood. Now the example also this polyp also in cases of gastric ulcer. In gastric ulcer also the patient might also vomited blood. So in cases of polyp, what happens is that when you do laparotomy, you open the stomach, then you can see a polyp form there. And when you remove that and you suture it back, it solves the problem. Yeah, so that's why sometimes they call it as what I call it benign tumor, or it's just like a neoplastic like lesion, because usually case can be resolved by surgical intervention. Well, the neoplasia in the small intestine, they actually involve more on the, what you call it, of a secondary rather than primary. Like lymphocytoma is more secondary tumor in the small intestine. Similarly, also adenocarcinoma. Occasionally, in the intestine also, they might have benign polyps. Okay. Oh, okay. So you finish our first part. Any questions so far? Class, any question?
None from me, Prof.
And for me too.
Tak ada ya. Kalau not, can we have break for about 5 minutes? Then we can come back at 10:50. Yeah. Okay. We come back. I'll join you again in 10:50. Okay. Thank you.
Prof.
Okay, Prof.
Class, can you continue?
Yes, Prof.
Yes.
Prof.
Prof.
So can you see my slide on the screen?
Yes, Prof.
Okay.
Yes, Prof.
Okay, thank you very much. So we continue with our lectures on GIT. And now we cover the liver. Yeah? We have 2 lectures on liver. So this is the first part lecture on the liver. Yeah? So digestive system, we cover the liver. You can see that there's a liver of pigs. And this is how you like the what I call it, the liver. We got the lobules. And this is actually the portal tract of the liver. So when you talk about liver, very important one, the cell in the liver is the hepatocyte. Yeah, hepatocyte is most important cell in the liver. When you talk intestine, enterocyte is the most important cell in the intestine. When you talk of the, what I call it, the stomachs, you got this mucus secreting cell, and you got parietal cell, which is important cell in the stomach. And you talk about oral cavity, of course, the epithelial lining that is so important is stratified squamous epithelium with those of the 5 stratum layer. And the most common one is stratum spinosum with regard of the viral infection, where the viral reside there and cause an infection. So the liver is the hepatocyte. Oops, sorry. Okay, so again, when we start with the new topics or new organs, I'll start with you with the review and function of the lobular division. I think the function is important because any abnormalities of the function as a presence of lesion in the organ, there is something that will disturbances the normal function of the organ. So knowing the function of the organ is so important. And then knowing how the organ look like actually, grossly and histologically, and in this case referring to lobular division. Like intestine, we have villi, you have crypts. In the oral cavity, we have squamous epithelium. So knowing those so is very important because by understanding that, so we can foresee which type of the cell or the hepatitis are expected in the lobular division and what is the impact of those lesions present in this cell leading to disturbances in the function. Then for these lectures, we will continue later with inflammation and other lesion in the GIT. But for today, we just cover very little on the general reaction of the liver to injury. Please remember, when we talk about general reaction, the reaction is more towards, we always thought about tissue response to injury. So this tissue response to injury, we have 10 type of lesion. So look at the function of the liver. And later on look at the lobular division of the liver. Liver have at least 6 important functions. The first one is to detoxification of metabolic waste product. So anything, those are the waste product will be detoxified in the liver. They involve also destruction of the spent RBC, synthesis and secretion of bile, synthesis of plasma protein, excluding not the immunoglobulin, yeah, more the plasma protein, and then synthesis of plasma lipoprotein. And liver also play very important with regard of metabolic function, particularly on glucogen synthesis as well as gluconeogenesis. It's reverse where animal usually starvation, leading to utilization of fat in the body in the process of gluconeogenesis to get energy to the animals. So this is a 6 common function of the liver. Then with this classification of liver lobules, there are 2 types of classification actually, but this depending on the book where you reach. Yeah? When you look at the old books, liver will be classified as pre-portal, or we call it portal lobule. Then mid-zonal, they call it mid-lobule. Then we have pre-acinus, or you call it central lobular. So this is what we have in old books. How old is it? Probably book something that before 1980s, something like that. It's old books. But in new books, they are referring that the lobule of the liver more towards a zone 1, zone 2, and zone 3. They are more on zonal. So this is something that lesson learned. Why this classification change? Please remember, knowledge actually keep on changing. We learn something actually based on the research finding. People do research, they find something, then someone will accumulate all those knowledge and they form a books. So what we have in the books, the scientific books, they are actually accumulation of information from individual research, but have been written by people that is specialists on those area. Meaning that they are specialists on those area, they do a lot of research on those part of the organs, and an expert, they have their own they have their finding, and are supported by other people working in the same area. So in this case, after people doing a lot of research, they found that the earlier finding is not really accurate. That's why they come out and update the knowledge. Knowledge is keep on changing, depending on the finding of research. Okay, so the book that we read, a scientific book, is outcome of many researchers that involved and being written by an expert. But in your case, like DVM student, probably you just accept whatever been written in the books. But later on, when you do your postgraduate or master or even PhD, then you will do more, but not say that now you can do also critical thinking. But when you do a PhD and so on and so forth, because you become an expert on the field, then you have more higher level of critical thinking. And when you read, sometimes you agree and sometimes you disagree what has been written in the journal or even in the books. Because easily maybe about 5% might not be accurate. 90% is accurate, but maybe about 5% or 1% might be accurate. That's why knowledge being improved because of that. So this one very good example where at one time people thought it's more on the lobule, but after new research finding, they put in the zone. In terms of pathology, maybe not important, but to me, the important here is for you with regard of lesson learned. When you go higher knowledge, then we will find that there is some changes. Maybe when you are a kid, our mom teaches 1, 2, 3, 4. But when you got bigger, then we found that there's 1.2, 1.3, or even -1, -2, -3. So which is actually what we call it, we have never learned when we are young. So they are deeper, then you got much more better information. And as mentioned earlier, knowledge is very broad. So what is important here is that when you look in terms of the classification or lobules or zonals, the new one is zone. For example, there, when you talk about zone 1, I'll show you later, this area, they have best supply oxygen and nutrient. So meaning that this is zone where they receive a lot of oxygen and nutrient. They have also play important role in glycogen synthesis and glycogenesis, glycolysis, protein metabolism, and formation of plasma protein, as well as detoxification of certain drugs. So that one is zone 1 of pre-portal zone. We call it, or maybe we call it is what we call it portal lobule. Then we have what we call it zone 2 or mid-zonal. We call it mid-lobule. In this case, they are responsible supply of blood and nutrient, but share function of zone 1 and zone 3. And while the zone 3, pre-acina, or previously known as central lobular vein, They are actually poorest supply of oxygen and nutrient associated with glycogen storage, lipid and pigment formation, and metabolism of certain drugs. This is a normal liver of pigs. You can see that those dot 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 actually is a lobules. Yeah? It's a very clear demarcation where actually this dot 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 actually being splattered by fibrous tissue. This normal in pig, but abnormal you observe this in other species or animals. Yeah? Probably in chicken they are not normal. You see those very clear dot dot with fibrous tissue surrounding it in a cattle. They are not normal, meaning that the liver has undergo fibrosis. But in pig, they are normal. And when you do histology, grossly, this is what you can foresee there. Good. You have those of the central vein is not clear there. You got the polythrite there, and then the liver lobule inside here. Okay. And this how when you look histology, which is common or normal in pig, but not common in other species or animals. You can see center there is a vein. Okay, then you got a polythrite here, T, polythrite. And then you got the connective tissue surrounding of the liver lobule, connective tissue. Okay. So I mentioned earlier, this is normal in pig, but in other species, when see a lot very clear this connective tissue covering the lobule, actually they have undergo fibrosis. But in this case, they are normal. For example, in this case, in human, you hardly see very clear demarcation as what you observed just now in the pig, isn't it? Because if you carefully there, the lobule, probably they follow of this line. Okay. So you got the central vein there, all the hepatocyte. Then you can see a lot of these polythrite, quite a lot surrounding, isn't it? So they are not well organized, what we do observe in the liver of pigs. So this is normal actually, okay, in human. So mean that pig a very good sample of liver when you want to study the morphology of the liver. And this is again, I mean, is in cases of in human, polythrite, you got central vein there, and you got the hepatocyte and the sinusoid. But again, they are not clearly demarcation of the connective tissue. Yeah, not clear. And this is actually the normal liver. What the normal liver, the most important one is the hepatocyte. So all those cells with nucleus, yeah, that one is actually the hepatocyte. And then you got line there, sinusoid, where blood flow in this sinusoid. And in the liver, they got a Cooper cell. Yeah, Cooper cell. Okay. And this is just a close-up there. You got sinusoid there, and you can see those of the Cooper cell. Occasionally, you can see a lot of those, what we call it, vacuoles, yeah, in the hepatocyte, usually comprised of fat. And this is a polythrite. So how you know it's a polythrite? There are four important structures present in the polythrite. The first one, you can see the bile duct there. So they are not central vein there. Then you can see also the vein, okay? And then you see the blood vessel with thick wall, okay? Then we got lymphatic also. So this blood vessel is artery, and this is blood vessel is a vein. And you can see in the vein there got RBC inside the vein. So this is the polythrite, okay? And that's why I mentioned here we have classical liver lobules and zonal of the hepatic acids. So as you see, there's now illustration. You can see that you got the polythrite, and the polythrite, they are present of bile ducts, vein, artery, yeah. And then this is central vein. In cases of old school of thought, which is actually what I call it, the classification of liver vein they thought that the blood supply from the central vein goes straight into the blood supply from the portal tract here, goes straight into the central vein. Yeah, so they go straight from the portal tract, go straight. So as a result of that, you'll find that area that's close to the portal vein, we might have a more blood supply compared with the area which is away from the portal vein. But after some time, they realized that this theory or this finding is not true. That's why they come out with zonal of the acinus, hepatic acinus, where actually they found that actually the blood flow from the central vein, they go into the side, then only they go into the inside. Meaning that they don't go straight. Yeah? Don't go straight means, like in this case, you got the portal tract there, they get side first, then only they go into the central vein. As a result of that, they created an area where they got zone 1, which is highly supplied by blood and oxygen as well as nutrient, followed by zone 2 and the zone 3. This again under an illustration I mentioned earlier in terms of classical, liver, lobule, and zonal. So in cases of what you call it zonal, you can foresee that the blood supply, okay, is increasing from the zone 1, zone 2, and zone 3. When in cases of classical, yeah, they are more involved with this type of pattern. I don't worry so much on this, but more importantly, I mentioned to you, you have to understand regard of those of different type of blood supply into the hepatic parenchyma. You're not clear later on, you can ask. So, sorry, maybe I can ask you. Any questions so far?
Prof.
When you talk about lesion, maybe less important, but what is more important in this case is that how knowledge change from the previous knowledge where actually they say that from the portal tract goes straight. So as a result of that, they found this portal area is more blood supply, got medium, then central vein. But the latest knowledge, they say that the blood supply from the portal tract go to side first, then they go acinus. That's why they go zone 1, zone 2, and zone 3. So the pattern of blood supply, this is more rounded, but this one different, isn't it? More this way. So that lead to the old books is go for classical or liver lobule. When you go to the new books, they go to zonation of the hepatic acinus. So when you read book, this is you can see those changes. Okay, question just now, sorry.
Oh, sorry, Prof. Prof, actually, I don't really understand. How does it go to the side and then it goes back into the central vein?
And then okay, the old thought, you know the old thought, the old research finding, they thought that the blood vessel from the portal tract goes straight into the central vein. Okay, so as a result of that, they found that what you call it, the portal tract area, the blood supply is more, follow the medium and central vein. But after some time, people do research, they found that this is not true. Actually, what happening is that actually the blood flow from the portal vein there, the portal tract there, they go aside first before they go inside. So as a result of that, they found in terms of the blood circulation, the zone 1, zone 2, and zone 3, zone 1 is higher blood supply compared with zone 3. So meaning that when you look at the hepatic lobule or parenchyma, the supply of blood is not like this anymore, but there are more supply of blood like in cases zone 1, zone 2, and zone 3. With regard to lesion, of course, there's something important and significant, but otherwise, a lot of lesion, because it's only classification. When it comes to lesion, animal might have a generalized, what you call it, hepatics, liver cell damages. What is the message here? Old classification, new classification. Can follow me? Or make me more confused?
The right side is actually the classical.
Yes, the right.
So
This is
so the
classical.
left side. Oh, okay. I got confused because bawah the Prof tulis zonation.
Oh, okay, sorry, yeah, because the bawah, okay. I think the drawing there, yes. Zonation is at the side, sorry. This one actually they are different. Yeah, you understand why you're confused because I put there a zone on. Actually, zone is here on the left side. Okay. I might do some correction later. Be confused. Okay, yeah. So
Okay,
the blue
thank you,
there
Prof.
is a zone here. The classical is here. Okay. The message is that there's a changes in terms of the classification. The message is that when you read book, they're different. They taught differently. So you read the old books, then you got the old classification. When you go to new books, they have new classification. Okay. Class, are you okay? I make yourself confused. No confused, yeah? I mentioned to you, you don't confuse. What is more important is that this how the old classification and now new classification people use this one. The what you call it, the zone, yeah? Okay. Not the lobules. Classical, lobule, zone, acinus, but unfortunately I'm sorry that those blues supposed to be on your left here and this one on the other side. Okay. Okay, thank you. And general reaction to liver to injury, I think this is more general. They are same as in other part of the body also. The only difference is that because they involve with hepatocyte. Yeah, they only involved with hepatocyte. And tissue response to injury, you have 10 type of tissues respond to injury. The only thing is that among those 10, this is the most common one. Of course, inflammation always there. Yeah, inflammation is more like systemic, so always there. Inflammation of intestine enteritis, inflammation of rectal stomatitis, infection of the stomach is gastritis, and now inflammation of liver is hepatitis. So inflammation is very important, fundamental, basic tissue response to injury. So you have to read those. You're not clear what is inflammation, go back to your what you call it, general pathology. Yeah. So degeneration, the first one. I think you understand those degeneration. Of course, the start of degeneration. The degeneration reversible. Then you have fatty changes, hepatic necrosis, and the ability of liver to regenerate. We have regeneration. And in the rate of necrosis, it much faster than rate of regeneration, or the rate of regeneration is slower than rate of necrosis, then they will undergo fibrosis, and the liver will undergo fibrosis. Hepatic parenchyma will undergo fibrosis. And when the fibrosis is severe, that's we call it as cirrhosis. I think cirrhosis, sometimes you always refer in general pathology as nutmeg liver. Okay. Then another response is hyperplasia of the bile ducts. Yeah, hyperplasia of bile ducts. Of course, they also, in this case, hyperplasia and proliferation of the bile ducts. And finally, we have there is inflammation or hepatitis. Degeneration can be classified as cloudy swelling. Cloudy swelling, namely due to damage changes in mitochondria, and this associated with ischemia or toxic injury, but sometimes also as a result of early stage of autolysis. So be careful also in this case when you have cloudy swelling, also as a result of postmortem change, or we call it autolysis. Yeah? So one is a cloudy shape. Another common is hydropic degeneration, and this partly because of accumulation of water in the cytoplasm of the, what you call it, hepatocyte. Common diseases involve intoxication or hypoxia, but sometimes a little specificity to the change. And sometimes also you might have difficulty to differentiate between hydropic degeneration and fatty changes. Like in other condition, hydropic degeneration is reversible. For example, remember that in the in the stratified squamous epithelium, stratum spinosum, when there is a infection of foot-borne disease virus, they lead to what I call atrophic generation. And in this case, atrophic generation, in many instances, there are more degeneration is reversible. But if the condition progress, they will lead to necrosis. And those necrosis might lead to severe damage of the organ. Another common also is fatty change. And in this fatty change, usually when you cut the liver, you can feel that the knife actually is more greasy, you know, you get a lot of fat there. The liver is yellowish in color. And this partly because there's abnormal high accumulation of fat in the cytoplasm of hepatocyte due to problem in the process of synthesis or secretion of fatty acid and carbohydrate metabolism lead to the deposition of fat in the hepatocyte. Very common, like in cases diabetes in dogs, but you see also pregnancy toxemia in sheep and goat, and azotemia in the cow. So you expect to see this fatty change. In fatty changes, because there's when there is a utilization of glucose is impaired lipid and metabolized, and lipid will be metabolized and energy source leading to liver function overloaded. Sometimes anorexia or toxicity of the hepatocyte in the pre-senile zone become fatty, and this fatty change can be reversible, but again, cell might burst and leading to necrosis. Hepatic necrosis. Many how people call it, the apoptosis, but more importantly is that more single cell necrosis. Actually, this necrosis is a programmed cell necrosis, and this apoptosis become so important partly because in cases of cancer therapy, people like to develop drugs that are able to selectively kill the tumor cell, but not other cell. Because monotherapy, when they give this therapy or medication to the patient, this medication might kill both the toxic or the tumor cell as well as the normal cell. So they are not very selective. Or the degree of selectiveness also not very good, not very high. So people try to develop something very specific where high degree or even 100% of the drug that is used, they only cause damage to the tumor cell by a programmed cell death. We call it apoptosis. And as a result of that, the tumor is not able to grow and the patient will recover. And the normal cell also not damaged. But this is still a lot of theory and be a challenges because many of the drug use are able to cause damages of the tumor cell, and a certain degree or small percentage cause also damage of the normal cell. So apoptosis is a single cell necrosis. And this can also occur in normal condition. For example, when you go to the intestine, those enterocytes will die within 3 to 5 days, traveling from the crypt or lubricum into the villi and extruded, isn't it? So that mechanism also is normal process, and we call it as even apoptosis. Natural programmed cell death, which is not harmful to the animals or to the host. So the pattern of necrosis, they're very straightforward. The first one, they can be focal, only certain area focal. And in contrast, those focal, they have also massive. I mean, it can cause massive necrosis of the whole hepatic parenchyma involving the hepatocyte. But they also sometimes follow the zone, yeah? Whether it is zone 1, zone 2, or zone 3. So pre-acinar or mid-zone necrosis or periportal necrosis. So they are what you call it can be followed those patterns also. And this is an example of pattern of hepatic necrosis. Like focal necrosis, usually You can see lesions are microscopically or very visible to naked eyes, and unfortunately, this focal necrosis sometimes have little significance of liver function, but may be important in some diseases. They are less important, probably just in nature that very small, very focal, and might not interfere with the normal function of the liver. Example of agent that can cause this focal necrosis, like in cases of salmonellosis, pseudotuberculosis, listeriosis, and pasteurellosis. Then we have a zone 3, okay, where actually this place as in a zone, with zone 3, the area is less of oxygen, less nutrient content, greatest concentration of mixed function oxidase, and usually damages of zone 3 can be regenerate, repair. As a result of that, they might lead to build-up perforation and recovery. So agent that focus probably tendency to have lesion in this zone 3 or the pre-acinar necrosis is more of case infectious canine hepatitis, passive venous congestion, fatty liver, copper toxicity. Sorry, those angular change is more of what you call post-mortem change. They are not significant. Then we have mid-zonal necrosis with zone 2. This is just in between of zone 1 and zone 2. And this is associated for the commonly of yellow fever. And the zone 1, which is uncommon, usually they are with inflammatory and infiltrated lesion or the portal shrine, may contribute to the biliary necrosis, which is actually as a result of phosphorus and chloroform toxicity. Massive necrosis, I think many of us experience of this iron dextran, what you call it, injection in the piglet, supplementation of iron in the piglet, and it is given excessively or wrongly calculated dosage, they can lead to poisoning, and very significant lesion you expect to see is a massive necrosis in the liver parenchyma. And usually due to acute vascular disturbances, endothelin in origin, and as a result of this, in long run, they might lead to post-necrotic fibrosis. The liver are able to regenerate. Regeneration are liver good. They can regenerate. There's ability to regenerate. And this complete regeneration is possible with 3 requirements actually. Liver are able to regenerate if there's adequate or blood supply, meaning that the blood supply is still there. Liver are able to regenerate when there is a free drainage of bile. And more importantly also, they are able to regenerate if architecturally, the architecture of the liver is normal. Meaning that the regeneration column or cell must have a guideline, the original fibrous and reticulum framework. So liver are able to regenerate. The issue is that when the process of regeneration is slower than process of damages, they might lead to fibrosis, or in worst form, they can cause cirrhosis. So fibrosis and cirrhosis actually is due to the chronic or prolonged injury, with result of progressive necrosis and fibrosis, mainly due to the rate of fibrosis is faster than the rate of regeneration. Rate of necrosis is more than rate of regeneration, that lead to fibrosis, and in severe form, they can lead to cirrhosis. So in mild injury, you don't expect to see any fibrous tissue. The immature collagen fiber form, and the process of fibrosis is digested by the enzymes if they have only the mild injury. So hepatic fibrosis or cirrhosis is something that is very important. I mentioned earlier, it's partly because the rate of necrosis is much faster than rate of regeneration. This example of fibrosis, where post-necrotic fibrosis involving with the liver parenchymal cell, diffuse hepatic fibrosis, partly because repeat parenchymal cell injury, pre-acinar fibrosis, particularly the injury around the central vein, while biliary fibrosis involving connective tissue of the liver in the portal tract. Liver, apart from hepatocyte, in the portal tract, they have bile ducts. And bile duct is very important to eliminate whatever elements present in the liver. And this bile duct involve the smaller interlobular ducts and intralobular colleges. They occur quite independently changes in the parenchyma and the portal unit. Usually this bile duct response is as a result of poisoning, and people believe there will be a proliferation or hyperplasia of the bile duct is their attempt to remove as much as possible the poisonous material present in the liver. So they need to proliferate. So one of the good example or lesion that we like try to look at in a chronic form of poisoning, to look at the bile ducts because there will be hyperplasia or proliferation of the bile ducts. Then the inflammation of liver, we call it hepatitis. And this hepatitis, I mentioned here, can be focal, can be diffuse hepatitis. An example or agent that can cause hepatitis, one is infectious canine hepatitis caused by herpes virus. So in liver, the herpes virus will multiply in the nucleus of the hepatocyte, and result of that, there will be hepatic necrosis. Yeah? There might be also toxoplasmosis, herpes virus infection, tuberculosis, and the last one, the inclusion body hepatitis. This inclusion body hepatitis also caused by adenovirus. But IBH is in chicken, while ICH is in the dogs, or the canine that is in dogs. But IBH is in the poultry. Cholangiohepatitis is inflammation of the bile ducts and hepatic parenchyma. And diseases that can cause that very commonly is salmonellosis, coliform infection, streptococci infection, and as well as fungal toxin. Okay. Oh. And any question? So we are, of course, we start early just now, only 40 minutes. We are 20 minutes earlier. Any question, class? Hello.
Not for me, Prof. Not for
Yang lain macam mana, ada tak? Ada soalan apa-apa or anything to share? I'm missing you because we have now face to face. Any question, class?
Prof, I have a question.
Yeah.
Could cholangiohepatitis also be caused by liver fluke?
Possible, yes. Yeah, because liver fluke, they will be, the adult will be present in the bile duct. Yes. Okay. When it comes to later on, when it comes to diseases of liver, one of the important is diseases of which is liver fluke, and I think in the country, the liver fluke is more common in buffalo rather than cattle. I've seen a case. The slide will show you later in the diseases of the liver, of course, the liver fluke. In that case, our case, and we got it from a liver fluke in buffalo. Okay. They can cause, yes. You are right. Any other question?
None from me.
Okay. Okay, if you have no question, we'll see you on Wednesday. Yeah? So that will be, we discuss more on the last lectures on the what you call liver, Then in the afternoon, we're going to have our practicals. Practical also focus on the liver. Plus, we're going to have tutorials. Get your answers and we discuss again. I think the first tutorial case study that we have, I think in principle you are doing very well. And of course, I do believe that for the second tutorial, you might have, or the case study, there will be much more improvement. Yeah? Because I mentioned to earlier, sometimes not because you don't know the answer, but probably each question require a certain thing to be there. And sometimes you might not able to give all those material. You might know, but because maybe you are not aware of that should be there. Okay. So we're going to have another discussion on the case study. Okay, and then this is your second no, you're going to have exam about 3 weeks time, isn't it? Is it 3 weeks time or 2 weeks time? Because I think I'm 1 week earlier. So we finish this week. You still have one more week next week, isn't it? One next week, then you can do. Then after that, you will sit for your what you call it, study leave and examination. Okay. Time fly very fast. Yeah? You almost completed your first semester online. Okay.
So Prof,
yeah.
just to update the test 3 schedule on 27th of January. In
27
the
January.
afternoon. Yep.
27 January. Yes. Okay.
Okay.
Main is okay. That's good. So your test 3 will be on 27 January. Discover the GIT and the Mazrina?
GIT and also endocrine.
Endocrine. Okay. Yep. Thank you, Dr. Mazrina. Kalau tak ada, we adjourn our meeting, our class, and then we're going to have our class on Wednesday. I'll see you again on Wednesday afternoon. Yeah. So thank you very much, and take care, all of you. See you on Wednesday. Thank you.
Thank you, Prof.
Thank you so much, Prof.
Thank you, Prof.
Thank you, Prof.
Thank you, Prof.
You're welcome.